Welcome to Roadmap to Residency. In this video, we are going to walk through high-yield fever workup questions that you are likely to see on your Step 2 board exam. This is not a full lecture on infectious disease. Instead, we are going to focus on how to approach question stems and use test-taking strategies to get the right answer, even when you feel unsure. If you have not already reviewed the fundamentals of fever workup, sepsis, and empiric antibiotic therapy, make sure to go through the infectious disease and critical care sections of your preferred question bank and board review resources before watching this video. That way you can use this walkthrough to sharpen your skills and reinforce what you already know. Make sure to like and subscribe so you do not miss our other board review content. And if you want one-on-one tutoring or residency application guidance, visit us at roadmaptoresidency.com. Let us get started. Here are our learning objectives for today. By the end of this video, you should be able to apply a systematic approach to diabetes management questions on your board exam. You will learn to recognize the classic clinical vignettes that come up over and over again for type 1 and type 2 diabetes. We will work on identifying the key buzzword findings that point you toward the right medication choice. And finally, you will practice choosing the correct management for emergencies like diabetic ketoacidosis and hyperosmolar hyperglycemic state, as well as chronic complications. Remember, these objectives map directly to what you will see in your question banks. After this video, go back through your endocrinology questions and you will notice these patterns immediately. The very first thing you should do when you see a diabetes question on your board exam is ask yourself two questions. First, is this type 1 or type 2? And second, is this an acute emergency or a chronic complication? For type 1 versus type 2, look for the classic demographic clues. Type 1 patients are typically young, thin, and present with diabetic ketoacidosis. They have absolute insulin deficiency. Type 2 patients are usually older, overweight, with a strong family history. They have insulin resistance. One tricky scenario the board loves is latent autoimmune diabetes in adults, which looks like type 2 initially, but the patient stops responding to oral medications and needs insulin. For acute versus chronic, if the question describes altered mental status, small breathing, fruity breath odor, or severely elevated glucose, think emergency. If the question asks about screening intervals, medication adjustments, or new onset proteinuria, think chronic complication management. This framework will instantly narrow your answer choices. Review the endocrinology pathophysiology chapters in your board review resources for the underlying mechanisms. Let us talk about buzzwords. On the board exam, certain keyword combinations should immediately trigger a specific diagnosis or management decision. When you see small breathing, fruity breath odor, anion gap metabolic acidosis, and a young type 1 patient that is diabetic ketoacidosis until proven otherwise. When you see extreme hyperglycemia, often over 800 milligrams per deciliter, with altered mental status and severe dehydration in an elderly type 2 patient, and notably no significant ketosis, that is hyperosmolar hyperglycemic state. And here is a classic pharmacology buzzword association. When the question mentions renal impairment with an estimated glomerular filtration rate below 30, or a patient about to receive intravenous contrast dye, they are testing you on metformin contraindications. The board loves asking about lactic acidosis risk with metformin. Write these buzzword associations down and drill them with flashcards. They come directly from the clinical vignettes you will see in your question banks. Here is our first case. Read this question carefully. A 52-year-old obese woman with type 2 diabetes on maximum dose metformin, and her A1C is still above 8%. She also has heart failure with reduced ejection fraction. Before you even look at the answer choices, what should you be thinking? The question is asking you to pick a second-line agent, but here is the test-taking strategy. The heart failure history is not just background information, it is the key to the question. On board exams, when they give you a specific comorbidity, it is almost always relevant to the answer. So before we go through the choices, ask yourself which diabetes medication has a proven mortality benefit in heart failure. Hold that thought as we walk through the answer choices on the next slide. Let us walk through this step by step. First, analyze the clues. She is on maximum metformin and still above target. That means we need a second agent. But the real clue is the heart failure with reduced ejection fraction. On the board exam, whenever they give you a comorbidity, it is driving the answer. Now let us eliminate. Choice A, sulfonylurea, causes weight gain and hypoglycemia, but offers no cardiac benefit. It is not wrong per se, but it is not the best answer when heart failure is present. Choice B, thiazolidinedione. You should eliminate this immediately. Thiazolidinediones are contraindicated in heart failure because they cause fluid retention. This is a classic board trap. If you see heart failure plus thiazolidinedione in any answer choice, cross it out. Choice D, ADPP4 inhibitor, is a reasonable diabetes drug, but it is cardiovascular neutral, meaning it does not help or hurt heart failure specifically. Choice E, insulin, treats the glucose but does not address the heart failure. The correct answer is C, an SGLT2 inhibitor. Drugs like empagliflozin and dapagliflozin have landmark trial data showing reduced cardiovascular death and heart failure hospitalizations. This drug class is a board favorite. Make sure you review the major cardiovascular outcome trials in your endocrinology and cardiology resources. Here is case 2, and this is a classic board question. A young type 1 diabetic who ran out of insulin, now presenting with the textbook diabetic ketoacidosis picture. Nausea, vomiting, abdominal pain, and small respirations, which is that rapid, deep breathing pattern. Her labs confirm it with a glucose of 450, a pH of 7.15 showing severe acidosis, a bicarbonate of 8, and positive ketones. Now here is where most students make a critical mistake. They see diabetic ketoacidosis and immediately jump to insulin, but the board is specifically testing whether you know the correct order of management. Look at her blood pressure, 90/60. She is hypotensive. She is severely dehydrated. What happens if you give insulin to a profoundly dehydrated patient? You can cause cardiovascular collapse and dangerous shifts in potassium. Think about the sequence of management before looking at the walkthrough. Let us break this down. The diagnosis is straightforward. This is diabetic ketoacidosis, but the question is specifically asking about the most important initial step. This is a management priority question, and the board loves these. Here is the critical teaching point. In diabetic ketoacidosis, fluids come first, not insulin. The patient is profoundly dehydrated, often with a fluid deficit of 5 to 10 liters. You give 1 to 2 liters of normal saline in the first hour. Why not insulin first? Because insulin drives potassium into cells. If you give insulin before checking and repleting potassium, you risk life-threatening hypokalemia and cardiac arrhythmias. Also, if the patient is severely hypotensive, insulin can worsen hemodynamic instability. So the protocol is fluids first, then check potassium. If potassium is below 5.3, replete it. Then and only then do you start the insulin drip. Choice D, bicarbonate, is a trap. Bicarbonate is only indicated when the pH drops below 6.9, which is rarely tested but important to know. The take-home message for any diabetic ketoacidosis question is to always think fluids, potassium, then insulin in that order. Review the diabetic ketoacidosis management algorithms in your critical care and endocrinology sections. This is one of the most commonly tested comparisons on the board exam. You need to be able to distinguish diabetic ketoacidosis from hyperosmolar hyperglycemic state. Here is how to approach it on test day. If the question gives you a young type 1 patient with an anion gap acidosis, positive ketones, and a pH below 7.3, that is diabetic ketoacidosis, the glucose is usually in the 300 to 800 range. If the question gives you an elderly type 2 patient with extreme hyperglycemia, often over 600 and sometimes over 1000, altered mental status, and notably no significant ketosis, that is hyperosmolar hyperglycemic state, the pH is usually above 7.3. The hallmark is a markedly elevated serum osmolality above 320. Here is the critical board pearl. The question stem will often include both glucose and pH. If the pH is low and ketones are present, it is diabetic ketoacidosis. If the glucose is extremely high but the pH is relatively preserved, it is hyperosmolar hyperglycemic state. Both conditions require aggressive intravenous fluids as the first priority. But hyperosmolar hyperglycemic state actually has a higher mortality rate, which is a frequently tested fact. Review the emergency medicine and endocrinology chapters in your board review materials for detailed management algorithms. Case 3, shifts to chronic complications. This is a bread-and-butter board question that comes up repeatedly. A long-standing diabetic with new microalbuminuria and uncontrolled hypertension. Here is the test-taking strategy. Whenever you see proteinuria or microalbuminuria in a diabetic patient, the board is testing one specific concept, renal protective therapy. Before you look at the answer choices, you should already be thinking about which class of blood pressure medication has proven renal protective benefits in diabetic nephropathy. That narrows your choices immediately. Also notice what he is currently taking, amlodipine. That is a calcium channel blocker. It controls blood pressure, but does not protect the kidneys from diabetic nephropathy. The question is asking you to optimize his regimen for his kidneys, not just his blood pressure. Let us break this down. The complication is early diabetic nephropathy, shown by the microalbuminuria. Here is the absolute board rule you need to know. Any diabetic patient with proteinuria or microalbuminuria needs to be on an ACE inhibitor or an ARB. These medications block the renin-angiotensin-aldosterone system and reduce intraglomerular pressure, which slows the progression of diabetic nephropathy. This is not just about lowering blood pressure. Other antihypertensives lower blood pressure but do not provide the same renal protection. Now let us eliminate. Choice A, a thiazide diuretic, helps with blood pressure but does not protect the kidneys from diabetic damage. Choice C, a beta blocker, is not first line for renal protection in diabetes. Choice D is tricky. Adding an ARB on top of amlodipine could work, but the better move is to replace the amlodipine entirely with an ACE inhibitor, since the patient specifically needs renal protection, and the ACE inhibitor addresses both the blood pressure and the kidney. Choice E, increasing metformin, does not address the renal or blood pressure issue at all. The correct answer is B, switch amlodipine to an ACE inhibitor. One more pearl, never combine an ACE inhibitor with an ARB. Dual blockade increases the risk of hyperkalemia and acute kidney injury. That is a frequently tested trap. Review your nephrology and endocrinology resources for the diabetic nephropathy screening and management guidelines. That wraps up our fever workup walkthrough for Step 2. Let us quickly recap what you should take away from this video. First, always determine if the fever is infectious or non-infectious, and whether the patient is stable or unstable. Second, for empiric antibiotic selection, match the clinical scenario to the right coverage. Community-acquired pneumonia gets a respiratory fluoroquinolone or beta-lactam plus macrolide. Sepsis gets immediate broad-spectrum coverage. Neutropenic fever gets an anti-pseudomonal beta-lactam like cefepime. Third, for sepsis, remember the management order. Cultures, then antibiotics within 1 hour, then aggressive fluid resuscitation, then vasopressors if needed. Fourth, for fever of unknown origin, expand the workup systematically to include malignancy and autoimmune causes once the initial evaluation is negative. Now here is your homework. Go into your question bank and filter for infectious disease and critical care questions. As you work through them, apply the frameworks we discussed today. You will be amazed at how many questions follow these exact patterns. If you found this video helpful, please hit that like button and subscribe to our channel. Share it with your study partners. And if you want personalized tutoring or residency application guidance, check out our expert tutors and residency advisors at roadmaptoresidency.com. We are here to help you succeed. Good luck with your studies, and we will see you in the next video.